delivery chemical. We're using a chemical that we want to deliver to a specific location, and then using then a coating of a platelet membrane coating on that substance, and then utilize the benefit and the interactions of platelets within our physiology to increase in the delivery of that substance. So this is really exciting technology, and this is what we're dabbling on, using natural agents. In my center, I know many other centers as well. So looking then at cell membrane coating technology. So we have coating nanoparticles with membranes of natural cells is increasingly explored to acquire cell-like properties for nanoparticle functionalization. So again, it becomes kind of like a cloaking device, using something that the body is used to seeing, and because of that, the body will respond to it as it's being part of its own. So we can then also utilizing the behaviors of platelets and how it interacts in the body. So nanoparticles coated with cancer cell membranes faithfully present the entire energetic profile of the source cell and elicit potent anti-cancer immune response. So this is another thing you can do then, is using these nanoparticles and then using the cancer cell membrane. So if you have then tissue of a cancer, and you nanonize that and add that into an injectable form, or you introduce at certain areas, and it becomes like a vaccine in a way, where the immune system can then develop an immune system response. So that's another exciting area then in regards to this technology. Then you have nanoparticles coated with macrophage membranes simulate the function of source macrophages and concurrently neutralize multiple pro-inflammatory factors, including LPS, the lipopolysaccharide, and inflammatory cytokines. Then you have nanoparticles coated with membranes of CD4 plus T cells or lung epithelial cells, or macrophage display the same protein receptors required by viruses for cellular entry, acting as decoys of the source cells to intercept and block viral entry to effectively inhibit the infectivity of critical viruses, like HIV, SARS-CoV-2, etc. So so this is just kind of showing some of the promises and some of the things that has been used so far, and played around with a little bit to kind of see what the potential that this kind of technology really holds. So then we have then the nanoparticles and coated with platelet membranes, which we will refer to as PNPS. So nanoparticles coated with platelet membranes, and this will then combines in the functionalities of natural platelet membranes and the engineering flexibility of synthetic nanomaterials, which together then create synergy for effective drug delivery and novel therapeutics, which is what this article is all going to be about. Platelets exhibit a circulation half-life of approximately 30 hours due to their possession of a CD47. It's a marker of self, that's inhibiting immune clearance and giving them then a unique ability for both passive and active drug targeting. Passive meaning that it's circulating for quite some time, for 30 hours, because it is a marker of self. The immune system will not really go after it, which allows it then the time to accumulate in the appropriate location. And then platelet also expresses in a set of unique surface receptors that dynamically adhere to things like damaged vasculature, tumor cells, and pathogenic bacteria. And these are the three different categories that we're going to be talking quite a bit about today, because these are huge areas of focus in the different studies that they're doing. So damaged vasculature, tumor cells, and then also pathogenic bacteria. But that also relates to not only bacteria, but viruses and spirochetes, fungi, parasites, all these other areas as well. So you have different examples then of these PNP binding. You have a platelet surface glycoprotein, GPIB, can bind to exposed collagen of damaged vasculature through von Willebrand factor to initiate tissue repair. So that's one of the things that these platelet then bind, and it's attracted then to blood vessels, and we're going to talk about the impact that it has in dealing with blood vessel damage that we have, or disease, cardiovascular disease. You also have P-selectin, which is a cell adhesion molecule upregulated in activated platelets, can bind to P-selectin glycoprotein ligand 1 or CD44 overexpressed on tumor cells, allowing for complex and dynamic platelet tumor crosstalk critical for tumor growth and metastases. So this is something that the tumors use to support its own growth and metastases. So it actually will use platelets in this function, and we can then use that function for our benefit. Then also we have them platelets that bind directly to pathogenic bacteria through that glycoprotein IB, leading to GP2B or 3A mediated platelet aggregation as part of the host response to remove the bacteria. So again, we're using these kind of adhesion and bindings that's naturally is taking place in the body, where the bacteria or tumor or damaged blood vessels are attracting the platelets. So if we can just use this then to deliver whatever pharmaceutical or nutritional agents we're wanting, we can then benefit from that. So again, the areas of focus for PNP studies is one, targeting injured blood vessels to treat vascular diseases such as atherosclerosis, angioplasty, myocardial ischemia, ischemic stroke, and pulmonary embolism. Another area is targeting tumor or circulating tumor cells for cancer treatment and detection. And 3, targeting drug-resistant bacteria for the treatment of infectious disease. And in regards to having something that's targeting circulating tumor cells is very exciting, because we know obviously traditional medicine does not really have any solution to that. In fact, all the different therapies that they do chemo, radiation, surgery, etc., tend to aggravate the activity of the circulating tumor cells. So it's actually making it worse instead of better. So then to find something that can address that becomes really exciting. So here we then have a PNP, and as you can see, we have kind of the platelet coating, platelet membrane. Then we have a solid core inside of that. And then we load that with a drug payload, whatever that may be, depending on what you're targeting and then also what you're wanting to address. So so the passive targeting, as I said, it's because these PNPs are able to circulate for such a long time. It is enabled them to get to the location just based upon that it hangs out for at least 30 hours. And active targeting has to do then with these different adhesion binding sites, these different binding sites like the P-selectin integrins, and that will then have a specific attraction to to targeted areas, like the P-selectin on the tumor circulating tumor cells, or the glycoprotein 2 or 1b that is then attracted to injured blood vessels and also to drug-resistant bacteria. So targeting then injured blood vessels to treat vascular disease, so we talked about the platelet adhesion, then also the activation of platelets and aggregation on the exposed subendothelial extracellular matrix during the vessel wall injury, is essential for our health, for our homeostasis. So that function is crucial. In atherosclerosis, we have then lipids, fatty substances that normally accumulate then at the vascular wall, leading then to endothelial activation and leukocyte infiltration. So we create then a kind of a leaky blood vessel there, and then also an inflammatory response there as well that over time then creates more and more damage. So these PMPs then can be used to deliver medication, such as the immunosuppressant rapamycin, or you can do rapamycin, then is then help to control some of that inflammation, to reduce the leakiness of the blood vessel, and then also to reduce that leukocyte infiltration so that the blood vessel has a chance to heal. And then also we have then PMPs can be used to deliver then medication. I'm sorry, we have the rapamycin, or it can also deliver gadolinium. This is then for detection and monitoring of atherosclerotic buildup. So you can load these PMPs with gadolinium, and they then become attracted to the injured blood vessel, and then all the atherosclerotic areas and also even atherosclerotic area will then light up. So then you can then see how far advanced something is. So this becomes another exciting aspect in regard to be able to monitor and then prevent a lot of cardiovascular event just by being able to kind of target and see what's going on much faster. Obviously, we don't like gadolinium, but sometimes you need these imaging agents. They do play a role sometimes. So then we have in angioplasty or stent-induced restenosis, mechanical damages to the endothelium lead to an exposed subendothelial extracellular matrix, ECM. The exposure then recruits platelets and leukocytes and triggers thrombosis and inflammation. So the subsequent cell proliferation and extracellular matrix deposition in the intima results in intimal thickening and vessel narrowing. So so we have that stent-induced restenosis and leading to this thickening and blood vessel narrowing, which is in itself it's kind of like the what's that domino effect. You're trying to help an area, but while you're trying to help it, you are then actually creating more harm. So PMPs then loaded with cytotoxic drug, docetaxel, inhibited then these neointimal growth and reduced the restenosis. So again, here you can use PMPs to target these areas to reduce and this thickening and blood vessel narrowing. And PMPs were also developed and to target myocardial ischemia, where thrombus in the coronary artery occludes the blood flow to the heart. So there are certain things that you can do then to target that area. Conventional reperfusion of the ischemic tissue bears risk of inducing oxidative damages and inflammatory response, which together then exacerbate the tissue injury in that area. PMPs coated with platelet membrane, conjugated with prostaglandin E2, binds with cardiomyocytes. So these nanoparticles encapsulated the whole secretome of cardiac stem cells purified from the cell culture media for delivery showed promise in promoting then angiogenesis, repairing damaged tissue, and restoring cardiac function. So here we have then a PMP, a platelet nanoparticle, and you coat it then with prostaglandin, and then you load it then with some of these cardiac stem cells, purified from a cell culture media. So then you can then drive these stem cells to the location to help to heal that damaged tissue and then restore cardiac function. So I thought that's pretty cool technology that we're playing around with, and having, if we can then drive these stem cells and kind of load stem cells into these nanoparticles, and then use the appropriate coating so that it binds then to the appropriate location, we can really heal tissue, and any kind of tissue. Here we have heart, but kidney, and also talk about blood vessel. I'm sure for neurological, you can do similar things as well as this technology is moving forward. So it's an exciting technology to see how it evolves. So then we have then treating ischemic stroke. So here they co-loaded these platelet membrane vesicles with some magnetic iron oxide nanoparticles and L-arginine, which is a precursor for the biosynthesis of nitric oxide gas. And then they intravenously injected that and accumulated, that accumulated in a stroke lesion due to combined target effect via the coated platelet membrane. And also then you have the external magnetic field. So they're using a magnet then to actually drive that iron oxide to the location. So that one then gets to that location will then release an L-arginine, and then so this released L-arginine triggered then local endothelial cells and platelets to synthesize nitrous oxide to induce relaxation of smooth muscle cells, promoted vasodilation, inhibited platelet activation and aggregation to restore the local blood flow in the stroke lesion. So here you're actually using platelets to prevent platelet activation and aggregation, so that we can then restore local blood flow in that in the ischemic area, so that that tissue can heal. Then in regards to tumors, and this is something that I really enjoy working with, and play around with this quite a bit as well. So here you have then the tumor recruitment of platelets. Primary tumors recruit platelets and form early metastatic niches that promote vascular permeation and tumor extravasation. So this just kind of show how tumors use in our system, our immune system, our platelets for its own benefit. Tumor cells also form thrombi with platelets for enhanced vascular adhesion and transendothelial migration. And during the metastasis, tumor cells shield themselves by attaching to platelets for protection against shear forces and immune attack, therefore increasing the chance of metastases formation. PMP can exploit these interactions for active targeting. So we know that platelets play a role in all these different areas. So, as the tumors then are using the platelets, we can then substitute the platelets and for the PNPs, and then do active drug targeting and drug delivery, using these PMPs. So PMPs have been made with different cores to deliver then various anti-cancer compounds for the treatment of cancers and different mouse xenograft models of colorectal cancer, liver cancer, breast cancer, and also you have ovarian cancer. So they've been playing around with those different cancers successfully so far. And I'm going the wrong direction here. So another exciting component is the PNPs, also used to target what's called small interfering RNA in vivo to silence tumor-relevant genes. And so to fabricate these small interfering RNA, they are loaded with a zinc and then also methyl imidazole, followed by coating with natural cell membranes derived from platelets. And then when these nanoparticles are endocytosed, by target cells, they're pulled into the target cell. The low pH of the endosomes cause escape then of these a small interfering RNA into the cytosol, into environment there within the cell. And then upon incorporating then with RNA-induced silencing complex, the target mRNA is then recognized and degraded, leading to gene silencing. So this is kind of how you can then use PNP to silence then these tumor-relevant genes. So, and here's a little picture. If you look towards the left, kind of upper on the left side, so you can see how you have then the zinc, MIM, and then the siRNA, and then you load that, you create that target, that membrane, that platelet membrane, that you kind of build around that those aspects. And then as that nanoparticle is then absorbed into the cell, and you can then see how it then becomes incorporated, and then the mRNA becomes recognized, and then it starts to degrade, that mRNA, that genetic. So that's kind of another exciting step in regards to what can be done in regards to controlling tumors using then PNPs. Then we have PTT and PDT, which is what I do quite a bit at my center, the photodynamic therapy, and then also the photothermal therapy. The PTT relies on photothermal agent delivered to the tumor tissue to absorb the energy from the external laser and transform it into heat to ablate the cancer cells. PDT uses photosensitizers to generate singlet oxygen upon laser excitation to kill cancer cells. So you have then platelet membrane coating, protected photosensitizer from premature oxidation and enhanced tumor accumulation. So again, it gives us more time to allow these photosensitizers to accumulate in tumor tissue. And then as you mentioned, tumors are attracted to these platelet membranes for its own progression, but also platelets are driven towards areas of inflammation, and tumors and cancer is an inflammatory condition, so it will naturally be attracted to that location. And as I mentioned earlier, in addition to solid tumors, CTCs have also become a target of these PNP-based therapies, including CTC killing for preventing metastases and CTC capture for early cancer detection. So if you this way you can then actually measure and see how many CTCs that are floating around, because you are coding them then with these PNPs, and depending on if you have some like gadolinium, or if you have some imaging substance, it will then light up, the CTCs will then light up, and you can then detect and see the level of them and also the locations of them. So here, and then the PMP, you have the multiple drug delivery. So in cancer, doing one thing is great, but if you have multiple drugs and deliver that at the same time, you can then increase the benefit. So you have here a recent study where you have tumor necrosis factor related apoptosis inducing ligand, called TRAIL, and doxorubicin. They were co-encapsulated into nanogel cores and then coated with platelet membranes. And TRAIL induced the apoptosis of tumor cells by binding to their death receptors on the surface, while doxorubicin intercalated into the nuclear DNA of the cancer cells and triggered the intrinsic apoptosis signaling pathway. So now you're going after then the cancer, the tumor cells, in multiple ways through a multiple drug delivery. And so together they generated higher anti-cancer efficacy than single drug control nanoparticles. So then going then into bacteria, which is one of the issues we're dealing with is the high level of antibiotic resistance. And this is because of overuse of antibiotics, and then also because instead of just having them go to the specific locations, when we take the antibiotic, it just goes everywhere. So if there's a way that we can increase the accumulation of the antibiotic where the pathogens are, then that obviously would be highly, much more superior. So nanoparticles are used to address this challenge of antibiotic resistance by targeting antibiotic payload to the bacteria to enhance drug potency. And many pathogenic bacteria, including several strains of staphylococci and streptococci, rely on the binding interactions with the platelets to promote their colonization and evade the host immune response. Such common and diverse platelet bacterium binding interactions have motivated the use of PMPs to harness the inherent bacterial adherence mechanism for targeted antibiotic delivery to treat then these bacterial infections. So here you have then MRSA, as a good example. The extensive use of new antibiotic, including vancomycin, linezolid, tedicillide, daptomycin, ceftaroline, tigecycline, has accelerated the emergence of resistant Staphylococcus aureus strains, especially towards vancomycin. Currently, virulent strains of methicillin resistant Staphylococcus aureus, MRSA, have become increasingly prevalent, imposing a paramount clinical challenge that threatens public health. So binding to the platelet is one pathway used by MRSA to invade the host. To exploit natural MRSA platelet binding for delivery, researchers used the nanoparticles to target vancomycin to the MRSA bacteria. Pathogenic bacteria also release virulent toxins to attack platelets and promote infection. So PNPs provide then a high specificity to neutralize these toxins. Bound toxins will lose their bioactivity, unable to cause further damage to these cellular targets or tissues before they're eliminated. So not only here are we then able, using PMPs, then to bind to places like MRSA to deliver as targeted antibiotics. Also, these PNPs are then able to then absorb these different toxins that are then aiming to attack the platelets, to promote infection. So this way we can then neutralize the toxins, and we can also go after the bacteria with these PMPs. So it's kind of a double function that can be really beneficial. So here are some additional promises of PNPs. You have PNPs, they inherit the biointerfacing properties of platelets and engage versatile and dynamic drug targeting to various diseases. So this is what we've been talking about. These biointerfacing properties of these platelets and how we can use them. And PMPs were made to harness the intrinsic affinity between platelet and inflammation for drug targeting. So we can have how platelets are driven towards inflammation. Obviously, inflammation are areas of need where tissue needs to be repaired. Drug molecules delivered via PMPs accumulated more in joints with collagen-induced arthritis and resulted in a notable antiarthritic effect. So here we can then use it then for joint restoration and reducing inflammation there. And also in a marine model of antibody-induced thrombocytopenia, PMPs neutralize pathogenic antibodies in vivo. So you can then use that to control a lot of the pathogenic antibodies, but also control some of the autoimmune situation as well, where you have antibodies that go after locations that is not wanted. And then also here, genetic engineering has recently been applied to modify platelet membranes for targeting CTCs or autoreactive T cells in type 1 diabetes. So again, CTCs, and then also promising in type 1 diabetes as well. So that is it for me. That I know it's a lot of technical things, but in essence, it's just understanding that it is using the properties of the platelets and how the damaged blood vessels or tumors or pathogens, how they interface with these platelets, and how we can then use that interface in order to be able to deliver treatment. So, and this is an exciting area. I mean, as I mentioned, it's I've done this, loading it with different agents. I mean, we've done nutritional agents. We've done things like artesunate to go after certain pathogens. Do different silvers. You can do different photosensitizers, like the methylene blue or ICG, or you can also use other agents like curcumin, and load it with that to be driven to areas of inflammation, and then kind of offload in that area to kind of heal the lining of the blood vessels or whatever, or if it is a joint. So there's a lot of exciting promises that comes along with this over and above as we're looking at these different drugs, but we can use them a lot with natural agents as well. Something that I haven't played around with yet, but I would like to, is to probably vitamin B17 and to use this as a way to offload B17 then into tumor cells and kind of see how the body, see how the response is from that. So thank you guys for listening, and hopefully I didn't make everyone fall asleep. Any questions? Again, I'm not the expert. I'm just presenting the article.
Well, there's no much expert out there except you and Dr. Patel and people in the group, because it's still under the research. So people are relying on you because you are the pioneers who are translating this work from research into clinical. It's not in the medical books. Mainstream medicine have no clue about it. So yeah, you are the expert. You are the pioneer, the first who's loading all those different drugs in humans. So definitely we would like to hear from you and have people asking you here. So there are any questions? And great presentation. This is one of the best presentation. I think you clarify a lot about go ahead. Dr. Beamer. Okay, he's not. So is any question there? I just want to clarify something about, you mentioned the platelets nanoparticles, there is passive and there's active. And passive is basically you have the pathology are leaky. Any pathological lesions, whether it's cancer, infection, or inflammation, their blood vessels are leaky. While the healthy tissues, their blood vessels are tight. So think about that. You have little open doors, which are the pathology, which are the blood vessels. They have open doors, and the healthy tissue, they have closed doors. So definitely, when you inject those platelets, they will be seeping into those leaky blood vessels, while they will not be going into the healthy tissue. And that's the passive delivery of nanomedicine mechanism. It's all about checking what's the difference between healthy and pathology. We find out the pathology is leaky, and what size that was good for leaking those nanoparticles. It's around 100 nanometer. So that's why all the nanoparticles we do, it's less than 200 nanometer to 10 nanometer, from 10 to 200. And that's all the sizes that they can leak into the pathology, while they will not be leaking into the healthy tissue, because they're too tight to allow those nanoparticles to go into healthy tissue. And then the active delivery is by platelets have receptors that has tendency to attach to an inflammasome, cancer cells, bacteria, and inflammatory cells, and viruses. So that is the active process. Just to clarify those two process for the audience here. But I think we're on the same page. Are you there, Dr. Michael?
I am. Oh, well, I'm sorry, Dr. Karlfeildth is there.
Yeah, no, I agree with you fully, exactly, and that's why, you know, with the photosensitizers, I mean, if you allow them to hang out in the system long enough, then you can use that passive process, you know, where because of that unorganized, leaky blood vessel creation that tumors and cancer tissue has. So you can use that to your benefit, or like you mentioned, you know, the active, where you can either coat then the nanoparticles with specific components to make them be attracted to target areas, or just using kind of natural adhesion molecules that exist on the platelets, you know, that the tumors are attracted to naturally, you know, which would be the active one. So yeah, absolutely.
Yeah, so you mentioned this is a very important part. In synthetic nanoparticle, they have to engineer, or they have to put receptors on those nanoparticles, like those phospholipids, in order to get into the pathology, into the cancer cells. But platelets, it's the beauty of it. It does have its own natural receptors. It's already there, that attracts to the cancer, virus, bacteria, inflammasome cells, etc. So that's the beauty of platelets nanoparticle. You don't have any need of interference by humans to add any conjugate antibodies to actively target those nanoparticles into the pathology, because the platelets being equipped already with the receptors that has tendency to attach to the tumors. That's why when you said, you know, the tumors, they use the platelets and cover themselves as a shield to disguise from the immune system, and so they can spread. Okay, so that's how, okay, if that's the case, then the platelets nanoparticle will definitely be, we can take advantage of that, and the platelets nanoparticle will be taking over, and those tumors, unknowingly, they will be using the platelets nanoparticle as a disguise, but those platelets nanoparticles contain toxins that will kill those tumors. So this is just exactly like a war tactic, knowing the weakness of your enemies, and try to use it to destroy it.
Exactly. Yeah, it becomes like a Trojan horse, which is exciting. And then, you know, using natural agents, you know, whatever it is that you're playing around with, you know, whether it is, you know, like we're talking about artesunate, or, you know, EGCG, or, you know, vitamin B17, or whatever it is that you want to unload depending on what it is that you're dealing with. For instance, if you're dealing with Lyme, maybe silver like argentin, adding that into, or EGCG artesunate there as well. So you can kind of play around with these different things and coat them with these nanoparticles, through the specific process that with the ultra sonification and then microfiltration, so that you non-ionize them and then use them as a delivery system, and really benefit from that. So it's really exciting to see what we can do with it.
Let me talk for a minute about drug delivery, if I could. When we talk about the mechanism of action of the endocytosis, where the platelet vesicle carries the drug in, those tend to be low in pH or high in pH, because one of the things that I when we're delivering a traditional pharma drug, like a doxorubicin or or a curcumin or something that's a molecule, methylene blue or whatever it might be, those don't concern me too much. But I get asked about peptides, and peptides are very pH dependent, and I'm wondering how or with regard to getting in my mind, or getting clear in my mind, a methodology that we could use this platelet lysate to deliver a peptide. We would want to ensure that the pH that is in the endosome during the endocytosis process is supportive. And I know that's a key area. So I just wondered, what have you had any information about that or thoughts about that?
I'm curious. I'm curious about that myself. So, yeah.
Well, we can work on that together, because I think it's an unanswered question that I'd like to move forward on, because if we can do that, if we can create something that's in the literature that's alternative to subcutaneous injection for some of these larger molecules by utilizing endogenous nanoparticles and endogenous transport systems, then we have a pretty powerful therapy. I would think, and it's endogenous, and it's an office-based therapy.
I think they're already being done this. Dr. Joseph James and Dr. Patel, they're already loading platelets with thymosin and with erythropoietin peptides. Here's the idea, and I need you to imagine with me that how this will work. When you take those platelets and then you mix them with peptides, proteins, and we sonicate it, we're making sure we're adding sodium bicarb to maintain and preventing the acidity of the environment that may cause any denaturation of the protein. So we're already adding almost 1 to 4 of sodium bicarb to keep the environment at a pH above 7. So we will not see any acidity there. So it will not cause any denaturation of the protein and keep everything integrity there. And then when you load them, think about, you have a vesicle loaded with those proteins, and then you inject them into the blood. Right. So if you are able to get those particles to the pathology tissue through the leaky blood vessels. So think about it. Okay, God throw the blood vessels leaky, and they're like those leaky blood vessels, those endothelium. They're like doors that's like a little bit slightly open. So and like a flap. So they will allow things to go in, but not out. Right. It will shut. So the platelets will start seeping out into the interstitial of the pathology, platelet nanoparticle loaded with, let's say, peptides. Now, in that environment of the interstitial, it's acidic. So we may think that this acidic, along with the stress and along with all these enzymes, that it will break loose. And that's enough. If I can get much of those peptides into the interstitial tissue, of the pathology, that's a big change in the bioavailability and the targeting of medication. Now, those cancer cells, they may take the platelets, nanoparticle vesicles, endocytosis, yes, and then you think about if they mix with the lysosomes, it may degrade. But some of them, when they get into endocytosis, they just break up and release the contents. That's one way. The other way is that not necessarily you get platelet nanoparticles going the whole as endocytosis. Those platelet nanoparticles, they can break into the tissue, and then those peptides will be picked up by the cells. But you're talking about, do you think not every endocytotic vessels has to go through acidic lysosome? Some of them will break up. Some of them will be released before even fusing with lysosome. There are many variables there, but just
I
getting
agree
the
with that.
drug there, that will be enough for my perspective.
Yeah, yeah. As long as we document that it works. So that's one of my things is I just want to make sure that, you know, if we're going to so there's a difference there. But it is profound when you look at the literature that I've seen, you know, by utilizing these additional transport mechanisms, these mechanisms the transport mechanisms are actually deliver more drug than diffusion by a good bit. Sometimes it's 2 or 3 or 4 times as much. So it's a more powerful tool. It has also a way of creating a sustained release effect, or like you say, a hanging around effect, which is a big deal. So yeah, this is wonderful stuff. The targeting aspect of this whole thing, I think, is fantastic. I just think we want to look at drug delivery and make sure that the drugs that we're trying to put in there are getting in them, and that we're getting lysosomes, you know, created and wrapped fully and fully formed, you know, in the process. And if we can do that by observation, I think even with microscopy, you could probably see that. I worked some with Dr. Park on this subject, and I think he has the technology to evaluate that even. So we could even send some platelet lysate to a nanoparticle investigator guy that could help us determine if these things are forming and how big they are, and even probably give you pictures of them. I would like to do that. If one of you wants to volunteer to produce the stuff, I would love to talk to Dr. Park about that.
Yeah, I mean, I think that'd be exciting to, you know, because that would create more validation,
yeah,
as to what it is that we're seeing and what we're delivering, and, you know, what we're doing. Is it carrying what we're thinking that it's carrying from the technique?
There's guys that are experts on this. Dr. Park, he's getting old, but he developed in dermatology. He developed what they called liposomal or nanosomal technology, and he's gone much further with it. Like he discovered it, I guess, probably 25, 30 years ago, and was successful with it. But he's continued right on working the whole time on these subjects, and not too many people really paid that much attention because they were satisfied with the first product. But he's gone further and developed it for peptides. So I wonder if there's a way we could, you know, really create a super cool process. But I love the endogenous nature of it. And I think that some guy, like a person like Dr. Park, could help us by quantifying the presence of the drugs in the nanoparticles. So
yeah, I think that'd be exciting. That'd be really exciting. Yeah, I'd really love to see that.
Yeah.
Okay, so let me add something also here. Does anybody has a question?
No, I was just going to comment on the fact that, yeah, it'd be nice to have like a full characterization, the pH, you know, the different cell counts or nanoparticle counts, and characterization, what's actually in it, what's being detected, if that's possible. I mean, that's just everything, to be able to use that as data to back up what we're doing.
It's going to vary by the patient tremendously, but at least we could show that the drugs are in the vessels.
Absolutely.
Right. The people who are doing lysosomes from the umbilical, those people, they may have the technology. It needs electron microscope to see the size of 100 nanometer.
Yeah, I think John Park can do that.
Right. And then Dr. Patel or
Yeah,
Dr. Zay or Dr. Micheal Karlfeildth will send you his a vial, you know, but needs to be done fast.
Right.
In other words, because those are not stable. We did not add PLGA, so they're not stable. It has to be done immediately, in other words. So I don't know the transportations will has any effect, because once
Even
we start
go to
injecting it.
Dr. Park's in Seattle, isn't he? I would go there and do it. You know what I mean? You can just go there and do it. Well, anyway, we'll talk about that later, but it's an
Right.
exciting idea. I just, yeah.
So let me add something. I'm just following up with Dr. Karlfeildth because his presentation,
Very
there
good.
a lot of information out there, a lot, and you can write a textbook out of his outlines. But I would like to take advantage of everything that he say and just elaborate more and see Dr. Micheal if you agree on that, because Dr. Andrew talk about the fungus infection and mycotoxins and how they are triggering all this chronic disease out there, and it's being it's being overlooked by the medical community. And if we think the same way that those platelets, nanoparticle, when we are loading them with antibiotics, they are targeting bacteria and they have affinity to attach to the bacteria and bypassing the resistance. It can be the same for fungus infection. Because it has a tendency to attach to any foreign, which includes fungus infection. So you can use it for fungal mold infection. And if you hear what Dr. Karlfeildth said, that those platelets nanoparticles, they act like detox package, and they can absorb toxins of the bacteria, which is the lipopolysaccharides of the membranes of the bacteria, which are toxics, right? And they can absorb them. They can do the same, and I think we need to verify it. Possibly can do the same thing with mycotoxins, because we have a hard time to detox mycotoxins. But possibly those platelets nanoparticles can do the same rule and detox the mycotoxins. And this will be a great news for Dr. Andrew Campbell, because he is looking for the technology to detox the body from the mycotoxin, in addition to kill those mold and infections. So what do you think, Dr. Karlfeildth?
Yeah, so I mean that's one of the biggest challenges, that the mycotoxins are produced by these molds, and that is what is neutralizing the immune system, so that we have a hard time, so the immune system can't go after the mold and kill it off. So if we have a strategy where we can then more effectively neutralize these toxins produced by these, to neutralize these mycotoxins, I mean, the battle is pretty much mostly won in regards to mold. And you have all these people that are dealing with multiple chemical sensitivities, where you barely just give them a little bit of an agent and they flare all over the place, say extreme pain, can't think, rashes, all of these type of things. So this can then become a really exciting strategy to absorb these chemicals, these mycotoxins, while you're then going after the fungus. And what's interesting is that they will then travel. So a lot of times you have mold mold spores that are trapped in different areas, and like in the lungs or tissues that the immune system has a hard time to get to. And then using platelets, they will then be drawn to those areas of inflammation and help to then to absorb and modulate the immune system function within that area. So I'd really be excited to see doing this on people that are dealing with complex chronic disease disorders, where you got mold involved, you got Lyme involved, you have other viruses, you have parasites, and see what happens. So I'm excited to see that.
So there's no published articles about it. I think there is some nanoparticles against fungus, but nothing is being clear about detoxification of mycotoxins. So you'll be the first. And if you can collaborate with Dr. Andrew Campbell, then we can come up with some studies, a way to verify that, because that will be some of the advancement that we can do in medicine. Also, we have here Dr. Sandra Garson. She is going to join CDP-MCS. She was recommended by Dr. Joseph James. So she's going to take Wisconsin, hopefully. She become the governor of Wisconsin for CDP-MCS.
Yes.
We have New York, we have Idaho, we have Illinois governors here. But I welcome her to join the family. And if she has any questions, please come up. I want to hear the audience questions. This is more of interactive discussion. We're learning from each other. We want to make sure that we scrutinize all the information. So I want you to come up to the mic and ask questions, verify those information that we are learning, because it's kind of a purview of all those facts and statements that we are laying down, and it's recorded. So I think it's going to be published in YouTube. So please, doctors, raise up your hands and speak. You don't need to chat. This is different from all other organizations and academies where it's one way and in a dictative way. No, this is more of both ways, and we want to learn from each other. I think we can learn better if you participate and involve and ask questions. So please raise your hands and ask questions. Thank you.
I'm Sharon, Dr. Sharon Hausman-Cohn, and my specialty is genomics. And I am also new to this organization, was just invited to come and listen today. But the question I have is, have you looked at if the response to these platelet particles relates to any of the things that relate to the blood-brain barrier permeability that interact with the platelets, like MMP9, because that also relates to who gets more chronic Lyme joint infections. It relates to stroke risk. It has a lot of overlap with some of the, and cancer cells use MMP9 as well. So I was wondering about the MMPs.
I haven't yet. I'd be very surprised. I mean, I haven't yet. Yeah, there's so many different, like with mold, where you're looking at VIP, MMP, and then also in cancer, like you have the MMP, VEGF, and IGF-1, and all these different markers. So it'd be exciting to categorize and see kind of the impact that these PMPs will have on that. I haven't taken that step yet. I'm not sure, Dr. Halasa, if what you've done in that area.
Well, I think that what she's talking about is genetic testings. This is more of delivery technology of those drugs, and whether those drugs that we're using, they are affected by your genetic testings. Of course, that's another subject, another level. That's what we're going to explore, me and you, and see how your genetic testing will help in screening patients who has errors in metabolism of the nutritions or the endogenous metabolites in the body. And that's your lab can do that. It helps us, for example, to know whether the body can metabolize vitamin D, can absorb it, can metabolize it. Do we have enough receptors for all those nutritions? Do we have where's the problem if there is a deficiency in any biochemical pathways? I think your nutritional genetics will help. But this is more of delivering drug to the pathology. And then the next level is how the body will use those nutrition and metabolize it. And if there's any genetics deficiency or problems or errors, that needs to be overcome by giving more nutrition, because all these variables between genetic variation from one person to another in dealing with nutrition and with absorbing and metabolizing those nutrition. You got my point here?
Yes, absolutely. I think that ultimately, though, there will be some variables based on the host's genomics of people who have, because the platelets are interacting as well. When you're talking about them going to the areas of leaky endothelium or to the areas of infection, people who have higher or lower expression of some of these different metalloproteases that cause the leaky blood-brain barriers may have better acceptance and uptake of the different platelet particles. And it just would be an interesting thing because to look at.
And we would hope they would, right? We hope they would. That's a good point. Every time we can target something that we can measure to get a quantitative result, that's a good thing too. You know what I mean?
Okay, any questions? Dr. Joseph, do you have any questions? Dr. Patel, Patel's supposed to be here talking. Where is she? Dr. Patel.
She's probably frozen to death to a post out in the yard. 20 below up there, I think. Gosh, I don't miss that.
Yeah, it's very
Oh.
cold there. I mean,
Yeah.
here.
Make a comment that, outside of having data to demonstrate what we're doing, I have done these treatments via nasal sprays and other means. And the good news is that I actually get results, and results that would be consistent with the mechanisms of action, the feedback I get from my patients. As I always say, my patients understand that this is experimental, but safe and natural, and that they are choosing to try this as I also try these methods on myself. So the good news is the experience I've gained over the past year, I can draw upon the clinical results as one way to back up what we're doing and what we're talking about.
Absolutely. Absolutely. Yeah, Dr. Joseph has presented some cases that were interesting, I think, with regard to or having utilized some of these treatments. So I agree.
I see the text. There is Dr. Cheryl. She asked some questions about circulating tumor cells. Dr. Cheryl, can you go ahead, grab the mic?
Yep, we got some in here. Okay, let me read these. Yes. Okay, what test do we use for CTCs? Is it Signitera? Do you like Signitera as the testing company for CTCs? Is a question to Dr. Karlfeildth.
He answered that with Biocept.
Oh, pardon me. I apologize. Thank you. Okay. Yeah.
And there are a number of ones in regards to CTCs. I mean, Signitera is good. Biocept, I like that one a little bit more. But they all have different strengths. So it's not like one is always better than all the other ones. One that I'm not a big fan of, which a lot of people are using, is the RGCC, because I don't feel like they are being very consistent in their results. And we've had other docs that have done sample testing from the same patient, one sample test from one arm and the other arm, and sent it to Greece and for testing, and got two completely different results. So it just make me then wonder a little bit about the accuracy. and it with CTCs, it's not always when you do a sample test that you are going to find CTC. So just because you don't find it doesn't mean that it's not there. It just means that it's not there in that sample. So it is good then to probably do it again and then repeat, to confirm. So it's not, CTC measuring of that is still kind of early technology in regards to how effective we are and kind of monitoring that and measuring that.
Would there be one? Go ahead. I'm sorry. Go ahead.
How often would you repeat that test? And why do you think Biocept is better than Signitera?
It just has to do with kind of the technology. I don't mind Signitera. I like Biocept a little bit more. It's just because they've been a little bit more consistent with me. But it's not that it's, as I mentioned, there are a number of them that are good. They all have their kind of strengths and weaknesses, and that's kind of that's a class in itself to go through the different ones and the technology that they use. But I can't remember the rest of the question. Sorry.
How soon would you repeat it if it was 0?
I probably, it depends on where they're at in their treatment. If you are suspecting that there's some activity going on, then I would probably do it within a month. If you have undergone treatment and everything else looks really good, and it's 0, then I probably would do 3 months. Then I probably, unless there's anything else that is concerning, then I feel comfortable to go further.
So, Dr. Sandra, you're joining the Chronic Disease Prevention Management Center, and I think we're going to do the training in your clinic. And I want you to, if you have any questions, please come up and introduce yourself. And we welcome you again. And we welcome any doctor here who's interested.
Okay. Yes, my name is Sandra Arce Garzon. I am a pediatrician, but I have been interested in regenerative medicine for a while. I'm sorry that I'm a little sick. I just got coronavirus, and sometimes my voice, it goes away. I had a question regarding thymosin alpha because I got coronavirus, and we were talking with Dr. Joseph, Dr. Halas, and Mike Beamer about how to get thymosin alpha. And unfortunately, it's not being available in some pharmacies anymore. Then we were talking also to Mike that maybe there is a possibility to have it intranasally. I don't know if you have any comments about that.
Dr. Mike, you're the blue genie. Beam, are you there?
This is a conversation from earlier. And what I wanted to do is put to the group, really, if here's my thing on this. I'm being asked, and I see other pharmacies at some points making these. But to be honest with you, with regard to thymosin alpha 1, the peptide, raw peptide in a CGMP form is available. I can get it. The problem is, can I create a dosage form of it that's stable and will deliver the drug, and that there's some data to show that that's likely to happen? For example, we wouldn't want to put it in oral capsules and start swallowing it. It's probably not going to do anything. So I want to make sure we have good data. And so far, I haven't really been presented with any data that shows me either one of two things. A study where somebody used thymosin alpha and successfully, created the desired effect in the patient with it intranasally, and if so, at what dose? And then the other question would be, is there any effect on the nanoparticle part of it? I'm wondering that if the nano delivery system might not be the right way to do that, as opposed to just simply making a nasal spray. So I don't know. I just wanted to talk about that. But the only studies that we see are on other drugs that are similar peptides, for example, interferon alpha or interferon gamma, or oxytocin might be an example. So I just wondered if anybody has comments on that, because there is a demand for it, but I want to make sure that we are all in consensus. This is something that's workable and that's the benefit of our patients. I think it's affordable to do. And it could be a lot easier way to do it if it's something that would work out well. So yeah, I'd just like feedback on that.
Dr. Joseph, are you there? I think Dr. Joseph is doing a platelets nanoparticles loaded with erythropoietin and thymosin alpha and beta already. Dr. Patel is doing it as well. I don't know if Dr. Karlfeildth is doing it, but and the size of nanoparticles intranasal, there's a lot of publication prove that nanoparticles does be taken, or it's being absorbed through the cribriform plate mucosa membrane. And they use also exosomes from the umbilical, and they spray it in the nose. At that size, that the cells can take them in by endocytosis and move them in. We already have data for that size of exosomes and nanoparticles. Regarding the peptides with that size, we have studies that shows interferon gamma is working intranasal. We have publication, I did share it with you. And if you say the size of interferon gamma, size of intestinal vasoactive peptide, also another one, it's the same size of thymosin alpha.
I noticed this pretty close, yes.
Right, so, and those are not protein. I agree, if it's protein, I don't think I will sniff them. But those are peptides, which are a few number of amino acids, around 20 or 30. So there is a potential that they can be taken. But we don't have specific study of Thymus and intranasal publication, but I saw for interferon gamma and intestinal VIP, vasoactive intestinal peptides, they're using it intranasal spray. And another one, which is the, well, you just mentioned it, the oxytocin as well.
Oxytocin.
And oxytocin is more bigger than the others, right?
It is, yeah. There's a transport mechanism for it. But yes, I do agree. It is bigger. It has its own receptors and stuff. But yes.
I can tell you from my experience, sometimes I've had to create a nasal spray because my patient absolutely refuses. Well, I mean, it's all their choice to inject. They just do not like the idea of injecting anything into themselves. So I did have a case that recent that I made a nanoparticle conjugated with ARA 290 and along with N-acetylcysteine and buffered it with sodium bicarb, and he had results like it. And I always get the feedback with results that I wouldn't necessarily expect. One of them was that his joints, now he's close to, I believe, 68 years old. He was having sort of like post-COVID fatigue. He had some erectile issues. He also, he has a history of osteoarthritis, but he said his joints felt a lot looser. In addition, he felt that his function had improved. His energy levels had improved. He tends to measure his heart rate when he exercises, how long he can exercise, and he's honest with his feedback. He's got no reason to exaggerate. So he was really excited with the results that he had immediately after doing this treatment. So, you know, I understand. I too want to find more evidence. At the same time, you know, somebody's got to go first, and you know, some, like the people I treat, they can't wait. Right. You know, the 20-year double-blind study. And I say that, you know, sort of jokingly, but as long as I know that there's enough evidence that I've translated from many articles that point to the fact that the risk here, you know, I don't see any.
There's no risk. I agree with you about that. There's not a risk of danger to the patient or toxicity of the drug. I totally agree with you. The only risk would be that we would just be unknowingly administering something that would be less potent than what we thought, and that becomes a problem for me, like regulatory wise. You know what I mean? And because that's what they hold me to, right? Is that, you know, when you say I was supposed to give the patient this, I gave him that. But I agree with you, Dr. Joseph, and I'm not opposed to doing this at all, really. Yeah,
Hello?
but I'm looking at, like, for example, I'm looking here on some things. If we can swap, if you don't mind taking the topic a little bit. You know, you got to store this stuff at very low temperatures. You know, but it's a super good drug. I mean, it really does a lot of fantastic things. So I'll get back with everybody, but everybody knows I'm looking. So if you have information to give me about this, just kind of pass on your thoughts to me, you know, privately, or not privately because we need to keep it private, but just so that we don't have to, unless we want to have a big discussion about it, it's fine. But, you know, I'm kind of looking at the latest papers that I've seen on thymus and alpha, and it looks obviously like a wonderful thing to have. But I'm trying to find the spot here.
Well,
oh, go ahead. Oh, it says.
Go ahead. I'm sorry. Go ahead.
Oh, it's Dr. Joseph. I'm sorry. Go ahead, buddy.
I was going to say, before I forget, the peptide that kind of might be a substitute for thymus and alpha that's available is something called thymolin.
Thymolin zinc. Yeah.
Thymolin, and you know, I'm, you know, as I told Dr. Arce, Sandra, that, you know, I'm just now going over the literature, and you know, it can take, I know for myself, sometimes I've got to at least review it 10 times or so before I really have a deeper understanding. But I suspect that thymolin has a similar effect of repolarizing the immune system, kind of like thymosin alpha would.
Low-dose naltrexone does too, a little bit, to a certain degree. And yeah, no, I agree with you about that. But like when I look at storage of thymosin alpha, it says thymosin alpha should be stored at -20°C. Lyophilized may remain stable up for 3 weeks at room temperature. However, for long-term storage, it should be kept below 180°C, stored in desiccated form. When ready to use, it may be reconstituted and subsequently stored at -40 degrees. Oh wait, and stored at 40 degrees Celsius room temperature for a period of 2 to 7 days. If the intention is to store thymosin alpha for a longer period of time, then it is advised to store it in a combination, Dr. Halassa here, with a carrier protein such as 0.1% albumin or bovine serum albumin, which is probably not that super different than the platelet lysate. I don't know, but it is recommended to avoid repeated freezing and thawing. It's just that kind of information is the stuff I'd like to put out there for y'all if we do it. But I'm open to it, and I think it's a really good idea. I think I'd be willing to do it if it's but I want to get a protocol for it from everybody and kind of some peer review. But I don't believe it's anything dangerous to people. I don't think that it's something that'll have no effect. I just want to make sure what we're doing is above board and that y'all know what it is.
Here's a good situation that I had. I was home in Michigan, and my mother's husband had COVID, but it was it was hard to tell if it was Omicron versus perhaps Delta. Because he had a loss of taste, and was actually, his symptoms were, I would say, worse than I would have expected for Omicron, because I've had Omicron. And after I left, his saturation was sitting at about 92%, and he was sort of dizzy when he would stand up. So my mother, she's a retired osteopathic physician, Dr. Dell. She gave him, I recommended, well, what do we have? Okay, now she had been taking ARA 290 injected for a colitis, but it's a very specific microcytic colitis that actually had improved it, the symptoms dramatically. And we started her on BPC 157, but we also had methylene blue. And what we did, and he had been doing the methylene blue mouth swishes and using the red light, the mouth light, in order to decrease the viral count in the mouth. But he was, I guess, he was getting a little bit irritated in the mouth after about 3-4 days of doing it. So I said, that's fine. Perhaps let's just put a few drops or a half a teaspoon in a glass of water and drink it that way. Because right now we need to buffer the redox. We need to continue to have solutions that are helping from an antiviral standpoint. And we also need to continue to try to optimize mitochondrial function so as not to be robbed of energy, which is very important when we're fighting COVID. So what we did is she gave him a glass of the methylene blue, half a teaspoon in water, injected him subcutaneously with BPC 157, a normal dose, 20 units. And then the ARA 290, I believe, 2 milligrams. I'd have to double check. It was 50 units, and I think that would have been equivalent to 4 milligrams. And within about a half an hour, he said, "Wow, I actually think I feel better." She rechecked his pulse ox, and it was 90. I think he was sitting at 97%. So there's a little evidence right there to show, there's situations where, it's like, what are you going to do? They're acute situations. And that was one that actually, he's now a believer. Okay. So, he's been hearing this stuff I've been talking about, but he's now a believer because he's gotten these results. But that's another kind of situation that's just it's outside the realm of just wishful thinking. It's like, what are we going to do?
Yeah, no, sometimes it comes down to that. That's right. You bet that's right. If you're the sick patient, it's dead serious to you.
Yeah, exactly. So sometimes these are fast acting and useful in acute situations. When you're trying to modulate the inflammation, BPC 157 is great at doing that. ARA 290, the reason why I did that is because it does reduce TH17. Okay. But there was an article I had read on the use of erythropoietin for severe COVID, showing extremely favorable results because and they were going based on the fact that some of the issues that the COVID patients were having were from sort of nerve dysfunction, in particularly like the phrenic nerve, which was inhibiting or hindering inhalation and exhalation, or optimal inhalation and exhalation, and that by sort of modulating the nervous system, they were having favorable results. Their results were better than if they did not use the erythropoietin. So, I just want to, every time I come at this, and I agree. I'm so glad Dr. Halasa continues to say, look, we're not shooting in the dark. We know what and why, what we're doing and why we're doing it. And we're using as much evidence that we have to back up why we're doing it, and understanding the processes, understanding how, say, COVID works, how viral infection works, how the immune system functions, and also realizing that, peptides, are different than just synthetic drugs that push buttons unnaturally. The body has a way of utilizing what it needs and what it doesn't need. And that's just been my observation with peptide therapy, that the body has, as long as there's always, you can go too far with anything, but I think if you inject within reason, you don't stand the risk of the side effects that a typical synthetic drug will have, because it can override the body's natural system.
I agree with you 100%. That's why people think, that's really what you hit on there, is the reason why the average person thinks quote unquote natural is better than synthetic is that, natural is limited. It's just like people used to say to me about what we call illegal drugs, that when they were in their natural state, they weren't all that dangerous. It's when man purified them, they became dangerous. So if you had a cocaine leaf off a cocaine tree, you could get a toxic dose, but when people purified it, now you have a toxic drug, and we kind of violate natural laws when we do that. When I look at thymus and alpha-1, really, and when you look at it from a regulatory standpoint, it could easily be perceived to be a nutritional supplement or a supplement sort of way, like we look at thyroid. I see here as I look at this further at this information in front of me on thymus and alpha-1, it's saying that essentially people with psoriatic arthritis are suffering from a deficiency of thymus and alpha-1 expression. So you could look at it very much just like rebalancing a thyroid system or hormone replacement therapy or any of that, if you put it in the context of a specific disease state. So it's not, it actually has a specific illnesses that can happen if it's deficient too, as well.
Yeah, exactly. So, and that goes sort of counterintuitive to what you would expect with psoriasis. If it's, you would think of it as a Th1 dominant disease. And if you give the thymus and alpha, you would think that that would worsen it. So, you know, but the more practice I have at this, and I just started doing lymphocyte maps. I don't have results yet, so I can see, you know, how much of this, what percentage of these cells that are releasing these cytokines that indicate Th17 polarization in relationship to T regulatory cells, and Th2 versus Th1. These are sort of like seesaws, you know. And that's the other thing I've noticed, is that for every molecular or cellular process, there's the counterpart. Everything's in balance with something else. In fact, I was discussing with somebody yesterday. There might actually be a rule of threes, where there's a yin yang, and then there's sort of like a fulcrum,
Right.
In the middle, something that connects the two together. So, you know, I feel like we're at the forefront of really, 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 truly understanding what's going on. And through that process, considering, well, why would, like when I used ARA 290, you would think, well, that would pull the immune system towards Th2. We don't want that. But he improved. Okay. But now there were other things on board as well. But sometimes it seems like it's counterintuitive what we do, but the body is utilizing the peptide the way it wants to. Now, that's just the way that's the only way I can explain it right now. And hopefully we'll have more clarity as we unravel some of these mysteries.
Well, maybe this is my idea is, let's say for COVID, we really need the immune system polarized to Th1 so we can kill those viruses. But if those viruses are not there anymore and you are post COVID-19, you need to really know exactly what your immune status is, so in order to really come up. But we have Th17 is a common in both sides. Whether it's Th1 dominant, you would have some Th17 dominant. And then if you have Th2, disease that Th2, they have Th17. So possibly you're taking advantage of inhibiting the Th17 in this part. And if there's any polarization to Th2, we can say, okay, so we can combine erythropoietin peptides with antihistamine. So antihistamine will take care for the polarization of Th2 in this case, and block that. And we take advantage of erythropoietin peptide now inhibiting Th17, and we give them with antihistamine. So in this combination, you are taking off whatever the unwanted effect of polarization to Th2. That's in case you have the virus is active. Now, post-COVID-19, it depends, and it's good to do cytokine profile, know exactly which is more, is it Th1 dominant or Th2 dominant, and then based on that, you can mix things in a way that makes sense to polarize it to either way. But the wanted effect of inhibiting Th17 either way, whether it's Th1 dominant, Th2 dominant, is still good. So in this case, I would argue that those peptides, if they're inhibiting Th17, that's great. And if they have any polarization to either Th1, Th2, we can add another drug to block that unwanted effect and move forward with it. So that's my thing. And there's a lot of problems where in some area, like you have multiple sclerosis by the Lyme disease, you really need to move the immune system away from Th1. But then maybe those patients with multiple sclerosis, they have cancer, and then you want to move the to direction of Th1 to kill cancer. So those cases where there's mix, and I think Dr. Patel is facing it a lot clinically, then that's where you have to go with a priority. Which condition you want to focus first? Is it the cancer or the multiple sclerosis? Because the treatment is different. Multiple sclerosis, you want to move away from Th1 to Th2 and Treg, and in cancer, you want to move them to Th1. But in both cases, you want to block the Th17 because it's draining the immune system. In both cases, multiple sclerosis, what you want to do with neutrophils? Nothing. It's damaging and inflamed. So you want to block that. You want to block Th17. In cancer, what I want to do with the neutrophils does not kill the cancer. We need more of Th1 and then lymphocytes. So that's where things they get into the mixing things, and that's where you need to prioritize which condition you want to treat, which one is more lethal to the patient, which one you prioritize. But there is a way that you can do where you can do more targeted therapy to the cancer and try to get as much as polarization Th1 there, while in the brain you need to work on the way that you help to move the things away from Th1. So, but those are the cases that are very complicated, and it requires that experience and expertise and prioritize what you want to do the first step.
Well, it's funny when you say that. Things are going through my head, and by the way, I think that is excellent. That is, seeing it clear and clear the way you explain it. It really makes perfect sense to me. The one thing I want to add is that, some of the things that, like, okay, ARA 290, it's sort of down regulating microglia versus up regulating Th1, or down. It's not like up regulating Th2 so much as it's modulating overexpression of Th1, and that makes me think that maybe perhaps it's moving. If the seesaw, can't think of the other name of it, the seesaw is way up for the Th1, then just nudging it down may not necessarily make it flip to the other side. Like that, it won't make the side that's up, the Th1, go all the way down to the ground, and then the Th2 side goes straight up in the air. But the other thing, I was thinking is there's other considerations. Now, ARA 290, I'm using that as the great example because it crosses the blood-brain barrier. It acts like a little jolt of erythropoietin without increasing the blood count and having those kind of side effects. But it actually only stays in the body for 2 minutes. So perhaps maybe it's more nudging, whereas the other peptides may be having a stronger, longer lasting effect on the polarization. And so maybe and I'm just throwing this out as brainstorming, that if we know that something is more of a nudger, it's having a short acting effect, we can take that into consideration, that if we need to think in terms of we've got to boost up the natural killer cell count, maybe we can boost that up without exacerbating the multiple sclerosis, because we're just going to nudge, we're just going to kind of keep it under control by nudging it, keeping the microglia from over reacting in the central nervous system. So I just wanted to say that those are things that I've been thinking about.
Well, it's very clear that erythropoietin peptides, it's even better than thymus and beta for neurological diseases, because you experience that by yourself. And multiple sclerosis is Th1, Th17 dominant. So if the erythropoietin is inhibiting Th17 and is polarizing the immune system to Th2, that's good for multiple sclerosis. But if you have a psoriasis is Th1, Th2 dominant in most cases. So you really want to move things, yes, to Th2, and you can still use thymus and beta, and you can still use erythropoietin peptides. But if you say that there's some psoriasis, by the way, they're not Th1 dominant Th17. Some of psoriasis, they are Th2 Th17. So that's very important. You can say 90% is Th1, but there's some of them, they are actually Th2, especially the one that's itchy, the one that you feel itchy, psoriatic. So that's where you need to work on that. And if you say, I'm going to add erythropoietin, take advantage of inhibiting Th17, but I don't want it, to move to Th1 in case of thymosin alpha, then you will say, well, I may combine it with, I may combine thymosin alpha with thymosin beta. And possibly that helps to counteract the effect of polarization to Th1 by thymosin beta. And there's lots of doctors are doing both thymosin alpha and beta together. That may be when you mix things, you can cancel the unwanted effect and get the wanted effect from that drug. So that's something possible. But I will not use erythropoietin peptides or thymosin beta to treat cancer. Just because, yes, it blocks Th17, which is good for cancer, but it polarizes Th2. If I have something better, which is one, which is thymosin alpha, which helps to move things into Th1 and inhibit the Th17. So I would choose the thymosin alpha. I will favor it over thymosin beta and erythropoietin peptide. So it's the and in cancer, you really need to work on many aspects. You need to add antihistamine to ensure you're blocking Th2. You may need to add low dose naltrexone to inhibit the Th17 further. So there is many mixed bag into treating cancer. And I think I'm putting together a very big presentation about integrative immuno-oncology. And I hope Dr. Patel will follow up with me with another more clinical perspective of it. But I have it ready. I'm just for any time when we don't have a speaker, I will be backing up. But next Monday, we have Dr. Parveen. She's here and she will be presenting on December 10. Possibly the other week, we will have Dr. Mike Beamer presenting also regenerative formulation for dermatological diseases. And definitely we'll have a speaker every week. But I do have a lecture that has the immuno-oncology, and it's actually integrative immuno-oncology and integrative immunotherapy. We're going to talk about all of this again, about polarization of the immune system. This is a new field of medicine about moving and shifting the immune system in a state of suppressing them using steroids. But it requires effort from everybody here in this room, where you need to practice it, and then you come up with cases and we can discuss it and find out the best option of treatment together. That's the whole purpose of having those sessions, is really for the clinician here to work with us as a team so we can optimize the protocols. And that's what me and Dr. Joseph James were doing a long time, and Dr. Patel and many other doctors who are in the group of CDP MCS. Hopefully Dr. Sandra will be joining soon. Dr. Karlfeildth, he's also CDP MCS. And that's what we do. We discuss it here, all the protocols and all the options, and come up with better solutions for your patients. That's the whole benefit of having this group. It's like a rounds in the hospital where we discuss cases and help each other and brainstorm and learn from each other here. So that's the reason I need all the audience here to be interactively involved and talk and speak and express. And if you also want to scrutinize information, that's some part of it. It's really not to agree on everything. We need to also disagree based on science, so we can scrutinize those science and making sure it's completely evidence-based. It's not biased from wishes that we like or things that we like to do, but it's something that has to be verified. So please come up to the mic and ask questions. Thank you.
Thank you.
All right. Well, if we don't have any questions, that's fine. We can kind of be done for tonight if we want. It's 20 after 9. We usually don't go past 10 o'clock, so we have plenty of time left if we wanted to take it. But it's up to whether we have questions or not. So, but yeah, I think this was a fascinating subject, and I think it's one we could explore a lot more. And the bravery and confidence of Dr. Karlfeildth, his therapies, and I appreciate it personally very much. I know if I were his patient, I would be feel in very good hands, and with the knowledge that he has about all these things. It's fantastic. So,
yeah, absolutely.
thank you, Dr.
I would
I would absolutely trust Dr. Karlfeildth. The detail and everything he's doing. I actually, I get a lot of referrals, patients, inquiring, and I think of two people. I also think of Dr. Patel with her experience of people that they can get a second, if anything, a second opinion. But Dr. Karlfeldth's experience and attention to data and detail is, and Dr. Patel as well, is just second to none in this dealing with these ultra complex cases that may involve cancer. I was going to say too, for Dr. Arce, Sandra, that one of the things I had mentioned is, the benefits of the ambassadorship. First of all, this is just my opinion, the value is way beyond the cost, period. Okay. I've purchased other programs, laser machines and things of that sort, and that, things that cost $80,000, $100,000 and making payments every month forever. And this is one of the things I think is good to understand is if you decide to go this route. I certainly do not try to convince anybody to do anything if they don't see it, if they don't see the value. But an added benefit, not only do you have two physicians coming to your office to help you sort out all those little things that are involved with the equipment. I can tell you, when I first got started, there's a lot of fumbling around to little things that you have to understand and know that make a big difference versus just seeing if you can just find out what the equipment is and try to purchase it somewhere. You need guidance with this stuff. Number two, you get the equipment. That's value in and of itself. But the other value is, as you're starting to consider these other strategies, trying to help patients that cannot get helped anywhere else in their experience, is that you can reach out to us and get one-on-one attention and get our take, an opinion, or if anything, point to a certain set of articles. That's really what it is to point out what we've been uncovering and reviewing articles, hundreds of articles over the past, collectively over the past 2 years, to make this transition smoother and get that one-on-one attention to help you to, get up to speed, because this stuff you don't learn this stuff overnight. One thing I can definitely say, and I'll end with this, is I sure found out how much I didn't know, after really doing deep dives with the molecular, cellular research and really understanding how cellular function works, and reviewing the mitochondria and having to learn it in detail and justify everything I do based on the mechanisms and the multiple pathways that are involved with these diseases. It's not just one bullet. It's multiple pathways that if you can address them all reasonably, then you actually start to get results that they have never had before. And that's been my experience. People who have not had relief, they followed some of the popular gurus. They've tried this detox, that detox, and they are getting very healthy, but they still have these symptoms that are preventing them from having their life back. And fortunately, I've been able to be a hero. Sometimes I'm not, and that's okay. Then we go back to the drawing board. But sometimes, using these techniques and concepts have allowed patients to experience relief in some arenas for the very first time. This is truly breaking new ground. The answers are always out there. That's my motto. The answers are out there somewhere. Okay. And you'll never hear from me, oh, well, deal with it. Live, you're this, you're 50, you're 60 years old. What do you expect? Or all the things that they get told. No, there's always something that we can do to improve on the situation. That's all we're trying to do is improve. So that's,
great. Yeah. As my dad used to say, if man made it, the body made it, the body can heal it, right? The body made the pathology.
Exactly. The other thing I've realized is that we have a much greater ability to heal, but we also have to realize that we are up against so many forces that are working against our minds, our bodies. And so, this is a tug of war, and we shouldn't blame ourselves, in my opinion, that we are dealing with symptoms of fatigue or brain fog or you name it, aches and pains or sleepless nights or whatever it is. There's stressors out there that are very difficult to defend against. And once you realize how far removed we are from, I always say the Garden of Eden, you realize that, yeah, this is very unnatural. The way that from what we eat, what we drink, even if you eat the perfect diet, you still don't even know what you're getting. So it's about trying to do the best that we can, and not just saying, well, there's no evidence to support anything, deal with it. That's just not acceptable for me, and that's why I'm here learning this stuff. And that's it.
Well, very good. It's driving you to be better at your craft, right? Better at your craft.
Yeah, exactly. And that's the thing. Practice. It's like you said, Dr. Beamer. You practice and you practice and you practice and you practice. Well, guess what? You get better. You get better. And we can't waiting for somebody else to figure things out. We have to be the pioneers sometimes. Sometimes it's okay. I've already been there, but look, some of us have been in the medical field for how long? 20, 25 years, 30 years. I mean, don't fool yourselves into thinking that that's a lot of time. You're a lot smarter than society makes you out to be. People don't that's a whole nother thing. But, there are people out there that really know their business in this arena. And there's some that don't. And we know that. But, we're a lot, after 20, 30 years of learning this stuff, I want to get some results, period. That's simply the case. And to think that we don't have answers is letting yourself be convinced by outside forces that you're not really that valuable. And that's bad. I think it's a good idea. I know it was for me to actually learn, keep practicing, and then suddenly you get a result. And it's a great thing. That's it. That's all I have to say.
Well, great. I appreciate it. I think, they say that the man who can read but refuses to read has no advantage over the man that cannot read in the first place, right? And as you learn more, then we improve. I good. Well, if we don't have further questions for Dr. Karlfeildth and his excellent presentation, let's clear it up for tonight, and we'll begin again next week. I believe next week we're going to have an interesting presentation. Let's see. Who's that by? I forgot who it was by. but she was here before. Oh, by Dr. Zarin, right? Is it Dr. Zarin? So would you like to give us a little preview of what you're going to talk about next week, Dr. Zarin, and we'll conclude our evening for tonight.
Sure. Thank you so much. In regards to the previous talk, so I would like to make a comment. So you understand that you're all coming from mainstream background. Most of you, they're medical doctors, but I'm a homeopath and I'm coming from a different domain. But the beauty of this, all the getting together or the meetings is to come to a solution, to integrate. So as far as I listen to some of you talking that there is no answer to many conditions, especially chronic conditions, but there is always an answer out there. So that's why I'm inviting you to come to my homeopathic workshop. To sometimes I know that you guys are all medical doctors and you're all open-minded. That's why you're inviting me to your group. So there is always an answer, because the human body has, by nature, is in the ability of healing ability is endowed in every single human body by nature. So the only thing that we have to do is, we are not healers, we are not physicians, are nature's assistants. So what we have to do is just to activate, to stimulate that healing ability in human body. And the nature does the job. So we are just assisting it. Homeopathy is a fascinating science, and is a true science. And we just have to understand that, because it's based on quantum physics. So I know that most of the medical doctors, they know mostly chemistry, but it's quantum physics is something that it might be sometimes beyond understanding, but when we're studying it, it makes so sense that how human body works at the different levels. So yes, sorry about that. Just hold on a second. Just. Apologize. I have some guests at home. So next week, yes, I'm an author of Quantum Anti-Aging, and I choose quantum anti-aging. Anti-aging literally means anti-chronic disease. So aging, in my view, is the same process of chronic disease. So I would explain it in my own way, and I simplify it as much as I can, because I wrote it for everybody with different background, different education, and so I simplified all the medical terms. I put 220 pages of my book into just 1 hour kind of workshop. So, and I'm offering it to you next week.
Wonderful.
So, and then you will get to know my view about aging, what is aging is all about. And unfortunately, it's wrongly accepted by society. They don't look into it as a